Okay, it is 6:01, and so we will go ahead and get started with tonight's presentation. Our two presenters tonight. The first is Dr. Stephanie Randall. She's an associate professor of child neurology and epilepsy at Seattle Children's Hospital and the University of Washington. She is the founder and director of the Tuberous Sclerosis Complex Program and is the director of the Epilepsy Surgery Program here at Seattle Children's. She has completed her undergraduate training at UC San Diego with a major in neuroscience. After working in a functional MRI lab, she went on to receive her Master of Science in Physiology and attend medical school at Chicago Medical School. She completed her pediatric residency at the University of Chicago and completed her pediatric neurology and epilepsy training through the University of Washington and here at Seattle Children's. Our second speaker is Dr. Amy Sato. She is a pediatric neurologist and a neuro-oncologist with special training in neurofibromatosis. She was born and raised in Southern California, went to medical school at UCSF, and did her pediatric residency, child neurology fellowship, and pediatric neuro-oncology fellowship at Children's National in DC. She joined Seattle Children's in 2018 as medical director of the Neurofibromatosis program and now considers Seattle home. So without further ado, I will go ahead and hand it over to Dr. Randall.
Great, thank you, Dawn. Thanks everyone for joining tonight. I will kick us off by starting to talk about tuberous sclerosis complex. I do not have any disclosures at this time. And these are my objectives. First, we'll define TSC, highlight the neurologic and non-neurologic complications of TSC, review the updated guidelines of diagnosis and treatment, introduce the TSC Alliance, our program here at Seattle Children's, and then provide you a little bit of information on research that we're doing here. So first off, what is tuberous sclerosis complex? It's a multi-system neurocutaneous genetic disorder. And as many of you may know, the challenges with TSC lie in the TSC1 and TSC2 gene that code for the TSC1 and TSC2 proteins. These proteins come together to form a complex that helps to regulate the mTOR pathway. And so the mTOR pathway is a pathway in our brain that really tells cells to grow and proliferate. And that may be great as the body's developing, but we need times to put the brakes on this pathway because without that, then we have overgrowth, which is kind of the hallmark of this disease. So I like to think of it like mTOR is kind of running rampant without the regulation of the TSC protein complex. I mentioned it's a genetic disorder that can be inherited in an autosomal dominant fashion, but the majority of cases, about 70%, are de novo. And you can have a mutation in either TSC1 gene or TSC2, with the majority of patients having a mutation on the TSC2 gene. So because the mTOR pathway is present throughout the body, you can have complications of this syndrome in almost any organ system. You can see listed here, and we'll kind of break it down a little bit further. As a neurologist, I spend the majority of my time taking care of the top part of the screen, as epilepsy, neuropsychiatric disease, and intracranial brain tumors are a common problem with this condition. And we'll talk about that a little bit more. But as a primary care provider or someone who may be referring a patient to our program, I think it's really important to know how these patients present. And so there was a really nice study done through Boston Children's where they looked at about 130 patients with TSC and how did they present. And actually, the majority of patients presented with a cardiac abnormality. That's very common in infancy. And in fact, we do see quite a few referrals from the prenatal cardiology clinic where the rhabdomyoma is actually seen prenatally on a fetal echocardiogram. So as someone who's seeing patients in clinic and you're doing your routine physical exam, if you hear a murmur and go on to get an echocardiogram and the echo notes a growth in the heart, you may want to consider TSC or at least a referral to our program to evaluate. The second most common presentation is the hypomelanotic macules, which I'll show you pictures in a few slides. These can be present at birth, although maybe harder to see initially and may become more obvious as babies or children get older and maybe get a little bit more sun exposure. And then the initial presenting sign of seizures was seen in about 15% of this cohort. So a large percentage, but certainly not nearly as high as some of these other signs that may come into your office. So focusing on the neurologic complications of TSC, almost everybody, up to 90% of people with this condition will have cortical tubers. And these are areas that I have kind of highlighted with the arrows that we can see on a brain scan. This is a flare sequence of a brain scan. And you can see that the areas are a little bit brighter. And those are just areas where the cells themselves either did not migrate to the right place, or when they did migrate, they actually were a little bit misshaped or malformed. And to be honest with you, we don't really put too much weight on these tubers unless you're having seizures or intractable seizures. We do not think that the tubers themselves lead to intellectual disability or trouble with learning, but we do know that they can be irritating and cause seizures. And so that kind of brings us to epilepsy and TSC. It's quite common. Again, from Dr. Davis's study, when they looked at about 130 infants, they looked at how many had seizures. And so you can see up to about 18 months, you could see up to almost 85% of people with TSC had seizures. And of that, in the first year of life, infantile spasms was the most common type of seizure, followed by focal seizures. So this kind of brings my second point that as a primary care provider, someone who's seeing babies in clinic, if a parent comes to you with concerns for infantile spasms, or if you have concerns for infantile spasms, we would want to see them urgently in the neurology clinic, because we know this is a catastrophic epilepsy that we like to treat early to improve developmental outcomes. And so I really like this video because I think it highlights the kind of the quintessential look of spasms, where the baby looks fine, and then they have an extension of the arms and a flexion at the head and a grimace to the face. It's very brief, just a second or so, and then they're relaxed, and then it happens again, and they cluster over and over. I'll just play it one more time. Sometimes people will say it kind of looks like a Moro reflex, but obviously you're not provoking a Moro in this baby, and the baby's just laying there and kind of repeatedly doing these movements. And so if we see a patient and there's concern for spasms, we like to evaluate them really quite quickly in our clinic. We can get kids in within a few days. Focal seizures, I mentioned, was the other most common type of seizure. And outside of that first year of life, when infantile spasms is most common, focal seizures then become the most common type. And the way we define a focal seizure is a seizure that's arising from one area of the brain. And I've listed some of the common signs we see. But really, when I hear a story of the child staring off, maybe their eyes go to one side of their body is stiff or shaking, then we start to think of a focal seizure. People with TSC can have generalized seizures, though, and so it's important for us to be able to differentiate because it might guide our treatment. And so, again, a generalized seizure we think of as kind of arising from the whole brain at one time, rather than starting maybe from one area specifically. And typically, patients and parents will describe like whole body shaking right away without that hemi-body involvement first. Sometimes you can have a focal seizure that then secondarily generalizes. And that can be hard to know if it was focal at the onset because sometimes it gets missed or the focal part is very quick. But we often will take a good history or try and get a video to see what type of seizure it is. And then I mentioned the reason why we care is that we have specific ways that we treat different types of epilepsy. So for infantile spasms in babies with tuberous sclerosis, vigabatrin is our medication of choice. Compared to patients without TSC, we usually start with a steroid, either ACTH or prednisolone. Outside of infantile spasms, we typically think of other conventional anti-seizure medicines to treat the epilepsy. And if we think it's a more focal epilepsy, we may choose a more targeted therapy like oxcarbazepine. If it's a more generalized sounding epilepsy, we may think of a more broad spectrum drug like levetiracetam, valproic acid, clobazam, for example. Excitingly, though, in TSC, we have two approved treatments that are a bit more targeted for this condition, which I have information on the next couple of slides. We do know that that about 60% of kids with TSC will go on to have refractory seizures, meaning that they may not respond to 1, 2, 3, 4 medications. And so we may need to consider other treatments such as epilepsy surgery, neuromodulation, and dietary therapy. And each one of these bullet points could be a talk all on its own. So suffice it to say, we have a pretty robust program where we start usually with a seizure medication and then can quickly move on to a different therapy if it seems like the medications aren't working for the child. So I mentioned mTOR inhibitors, and you'll kind of hear about mTOR inhibitors a lot in this talk, as this is kind of the staple of treatment we have for most of the complications of this disease. Currently, it comes in two forms, everolimus and sirolimus, and we use them interchangeably, although I would say most of the studies really looked at everolimus, and that's often where I start, just as a personal preference. It's an mTOR inhibitor, so as you remember, the problem in TSC is there's overactivation of the mTOR pathway, and so the purpose of this drug is to kind of push the brakes on the mTOR pathway, as the TSC protein complex should be doing. And fortunately for us, it was approved for the treatment of focal epilepsy back in 2018, so we have some extensive use with the medication for epilepsy. And then here's a reminder of the picture again. So the TSC protein complex is the challenge in this disease. It's not functioning normally. So mTOR inhibitor is kind of acting as the TSC protein complex should. I mentioned that we also have cannabidiol or Epidiolex as a targeted therapy for epilepsy and TSC. Epidiolex was approved in 2020 for a treatment of medically refractory epilepsy and tuberous sclerosis, and actually only carries two other indications right now, one for Lennox-Gastaut syndrome and intractable seizures, and then Dravet syndrome with intractable seizures. It's the non-psychoactive derivative of marijuana. It does not contain any THC, and so we often will encourage families, if they really want to use a CBD product, we'll try and get this medicine prescribed for them instead of using like an over-the-counter product. I should mention that the mTOR inhibitors and Epidiolex are usually well tolerated. With both, you can have some GI irritation. And then certainly with the mTOR inhibitor, we're worried about some immune suppression, and so that's something we follow quite closely. So kind of moving away from the epilepsy, almost everybody with TSC has what we call subependymal nodules, or growths within the ventricular system or the lining of the ependymma. These, in the majority of patients, don't grow. They're there. They stay the same size over a person's lifetime. And so we don't need to worry about treating these. We do follow these every year or so with an MRI. And if they grow or evolve, then we use the term subependymal giant cell astrocytoma, or SEGA. And SEGAs are actually quite rare. Only about 25% of people with a subependymal nodule will go on to develop a SEGA. But like I mentioned, we get screening MRIs regularly to make sure that SEGA isn't developing. The complications of a SEGA, as you can imagine, is that you have a mass growing in a fixed area. And so it's also in an area that's very close to the ventricular drainage system. And so if it gets too big, or if it gets positioned in a certain way, it can block flow and cause obstructive hydrocephalus, which obviously can be quite detrimental. Rarely could it bleed and rupture, and even more rarely could it transform into a malignant brain tumor. I haven't seen that yet, but there have been reports of that. So the way we treat SEGAs comes in three forms. In a patient who has a small SEGA, then we will usually start with an mTOR inhibitor. As I mentioned, the same medicine we can use for seizures, everolimus or sirolimus. If that's not tolerated, or the SEGA continues to grow despite the mTOR inhibitor, then we think of a surgical intervention. Typically, we'll try laser ablation, as that's less invasive and can be quite effective. And if a patient comes in, let's say with an MRI like this, where we're worried about obstructive hydrocephalus and they're symptomatic, we may need to offer a resective surgery urgently. Moving on to the last neurologic complication of TSC is what we call TAND, TSC-associated neuropsychiatric disorders. TAND kind of encompasses, they break it down into 6 elements. But really, we like to think of behavioral issues related to TSCs. You can see listed here. Sleep problems are very common. We partner very closely with our sleep medicine colleagues, as well as anxiety, depression, language delay, etc. Autism spectrum disorder and ADHD are seen a much higher percentage in this condition as in the general population with ASD or ADHD. Many of our kids will need help in school with their intellectual disability, their academics. Often they may need to partner with a psychiatrist or a counselor to help with some of the psychiatric components. And then we do work very closely with neuropsychology to help with some of those issues as well. TANT can be quite frustrating because we don't have a good treatment or a good fix for many of these issues, something that the TSC Alliance and the community has been working on. And so moving on to the non-neurologic complications of TSC, I briefly mentioned cardiac rhabdomyomas. These can be seen on fetal echocardiogram as well as postnatally in infancy. And interestingly, these tend to get smaller over time and may even fully regress. And so it's unique to the cardiac rhabdomyoma that they may get better or go away. In all the other masses in TSC, they tend to get bigger with time if they grow. Typically, these don't cause any issues unless they're located in an area that's causing obstruction, or if they're located in an area that's going on to cause an arrhythmia. So most of our babies will follow closely with cardiology, may even need a Holter monitor to look for an arrhythmia and need treatment for an arrhythmia. I have 5 of the dermatologic manifestations here, the most common being the hypomelanotic macules or ash leaf spots. These can be seen actually in the newborn period, but like I mentioned, become a bit more obvious as the skin gets more pigmentation or if the patient gets more sun exposure. They can be seen anywhere on the body. The other most common finding we see is the shagreen patch that's typically located above the buttocks on the back, and it has like an orange peel texture and appearance to it. That can be present in the newborn period as well, though it tends to develop as patients get a little bit older, as do the facial angiofibromas. These can be quite frustrating and disfiguring as they can proliferate and become quite extensive on the face around the nasal bridge. They can certainly worsen with sun exposure, so we give a lot of education about that to families. More commonly seen in adulthood are the ungual fibromas. They can be seen on the fingers or the toes, and then forehead cephalic plaques. What I don't have pictured here are the dental complications, which can include small pits in the teeth. Retinal hamartomas are seen in about 50% of kids or people with TSC, and typically don't cause any issues, although if they overlie the optic disc, they can lead to challenges with vision or strabismus. Renal angiomyolipomas and renal cysts are quite common, seen in about 80%. They tend to develop as kids get older, not as common in the newborn period for the AMLs. If you have a mutation on the TSC2 gene, which is located on chromosome 16, that's actually quite close to the polycystic kidney disease gene. And so sometimes you see overlap and patients can have complications of both disease. So you can see in one of our patients here who has polycystic kidney disease, certainly that can be seen in the newborn period. Having a good partnership with nephrology is important for these patients. Lymphangioliomyomatosis is a complication of the lungs, not common in pediatrics, although we have seen it a couple of times in our cohort, something that the adult TSC providers tend to follow more closely. You can see that there are cystic areas that develop in the lung parenchyma that put patients at risk for a pneumothorax. And so can be one of the most common morbidities related to TSC. Fortunately, not something I've had to deal much with, given the fact that we think it's more often age-related and more common in women, thought to be modulated by estrogen. So moving on to treatments kind of for the non-neurologic components of TSC, I kind of clumped them all into 2 slides because it's kind of the same thing for everyone. So an mTOR inhibitor is typically what we'll think of if someone has any of these significant complications, although with cardiac rhabdomyomas, most babies don't need treatment. The cardiac rhabdomyomas typically involute with time, although if it causes an arrhythmia, they may need an antiarrhythmic. If it's causing any outflow obstruction, they may need an mTOR inhibitor. Same goes for the retinal astrocytomas. We have used mTOR inhibitors in the past for growing astrocytomas that are obstructing vision, although it's not approved for that at this time. Facial angiofibromas, we have a topical cream that has been approved, and it actually works quite well, especially if started early. So we have our patients follow closely with dermatology, and sometimes they'll offer laser therapy if the angiofibromas or the forehead cephalic plaques become disfiguring. In terms of the renal AMLs and the pulmonary LAM, mTOR inhibitors are the first line of treatment if the AMLs, once they get to a certain size. But certainly we can consider other treatments like a laser therapy to the renal tumor. Sometimes I've even had patients go on to have a nephrectomy or a resection of part of the kidney. And then this can often lead to hypertension, and so patients may need an antihypertensive medication. So in 2021, the TSC consensus group came up with the revision of the diagnostic criteria. You can see we have 11 major features and 7 minor features. I have reviewed the majority of these features today, and to have a diagnosis, you need to have at least 2 major features or 1 major and 2 minor features. And then the surveillance and management, again, was updated in 2021, just following these patients closely with the respective providers in each organ system. And typically we will do a brain MRI and abdominal MRI every 1 year or so. Sometimes we can space it out a little bit longer if patients are really asymptomatic. The other new recommendation is for any infant under the age of 2 with TSC. In the first year of life, they should have an EEG about every 2 months. And then in the second year of life, they should have an EEG about every 3 months, and that's to screen for signs of infantile spasms. And so that's a new recommendation. So quickly, I'd like to just talk about the TSC Alliance. It's the patient support group that was founded in 1974, initially founded by 4 mothers who started the organization, and since has really grown to be a wonderful organization that's comprised of families, researchers, physicians, nurses, et cetera, that have really brought a lot of awareness and education about this condition. The TSC Alliance has a pretty strict criteria on what sites can be considered an approved clinic, and we became an approved clinic in 2017, and actually this year just became a center of excellence, so we're really proud of that. And you can see on the map that we cover a pretty broad area, with the next closest centers being in Colorado and Northern California. So our program is comprised, this is our neurology group. Here's myself, I work with a nurse practitioner, Susanna, my nurse Allison, our scheduler Lucy, and our clinic coordinator Claire. And between the 5 of us, we're quick at getting patients in and making sure their care is followed closely and getting them scheduled appropriately. We have a multidisciplinary clinic that meets 6 times per year with the following providers here, really allowing us to have a team approach to taking care of these complicated kids. And then in addition to that, we have 2 dedicated neurology epilepsy TSC clinics per month, and then 1 that's partnered with neuropsychology. So really making sure we're addressing the epilepsy and the TAND issues as best as we can. I have listed here the goals of our program. Really what we had wanted was to make sure that we provide the best care that we can for our patients, really limiting the amount of trips they need to make to come to our clinic, knowing that patients can travel from quite a distance. And it's allowed us to raise awareness in the community, partner with the TSC Alliance. We have trainees in our clinic all the time. I had someone with me today. So we're always teaching a new generation of pediatricians and neurologists about this condition. So in the last couple of slides, I just wanted to talk about clinical trials that we've done and are doing. You may have heard of the PREVENT study. It was recently published in August. This was a study that was done over the course of about 6 years that looked at babies with TSC without seizures. And the question was, does vigabatrin prevent the development of infantile spasms, focal seizures, and improve developmental outcomes? Unfortunately, I know this is hard to read, but I'll just give you the highlights that unfortunately it was a non-superiority study, meaning that preventative vigabatrin did not improve the risk of focal seizures or time to seizure onset. It did delay the time to infantile spasms onset, although um, on the right here, you can see the developmental outcomes and whether or not you were treated with vigabatrin, placebo, and or when you were treated, it didn't matter in terms of the Bailey and the Vineland. And so unfortunately, we were hoping to get a different result, but it's important to know that preventative vigabatrin may not be the answer for this condition. And I think that's good. We now know that we don't treat preventatively. We wait and see if a baby goes on to develop seizures or infantile spasms, then we would initiate the medication. We're involved in 3 clinical trials right now at Seattle Children's. The TSC STEP study is a new iteration of the PREVENT study, like I just mentioned, looking at the use of an mTOR inhibitor in babies with TSC, asking the same question: does an mTOR inhibitor started preventatively improve the risk of seizures, spasms, and development? So we'll see. Hopefully, we'll have some good outcomes for this study. We're also part of the TRUST TSC study, which is looking at the use of a medicine, a neurosteroid called ganalaxone, and seeing if that helps with the refractory epilepsy that these patients experience. And then finally, we got a grant through Seattle Children's to look at MRI HASTE studies. And those are the quick MRIs that do not require sedation, to see if a child or a baby can undergo a quick 1-minute MRI compared to a full scan, see if that gives us enough information about SAGAs. So we're almost through recruiting for that, and hopefully we'll find that the quick studies are sufficient. That will save our patients a lot of time and energy. So with that, I'd like to thank you for your attention. I have our contact information at the bottom. We'd be happy to see anybody in our clinic and answer any questions that you have. Every year we do a fundraiser for the TSC Alliance, and you can see a couple pictures from the walk. And as part of the fundraiser, we do a pie in the face celebration for however much money we raise. So we have a lot of fun in our group and have been contributing to the TSC Alliance as best as we can. And so we'll be happy to take questions at the end after Dr. Sato's talk. So thank you very much.
Thanks so much, Steph. Dr. Randall, I always learn so much hearing from you. I'm just going to take a second to get my screen shared here. And thank you all again for joining after hours. Thank you. My name is Amy Sato. I'm here at Seattle Children's, the medical director for NF program. Thank you so much for making the time. And I was actually really excited to see some of the names of our attendees. I haven't met many of you, but we have had many mutual patients together. So thanks again for talking, and we love working together. Okay, I don't have any disclosures either. And we can just talk about in the next 30-ish minutes, what I hope to do is to give a little NF 101. We'll talk about the different NF conditions, NF1, NF2, schwannomatosis, and then just review the diagnostic criteria of NF1. I was hoping to spend the majority of our time talking about the complications and management of our kids with NF1, and then at the end with how to refer to our program, and hopefully we'll have time for some Q&As. And feel free to put any questions in the chat, so we will get to those at the end. So a little NF 101, neurofibromatosis, referred to as NF. When someone says NF, it can mean a bunch of different things because it is a heterogeneous group of inherited or hereditary tumor predisposition syndromes, and they can affect to central nervous system tumors, peripheral nervous system tumors. The reason why most people say or refer to NF1 when they are saying NF is because it is the most common. So NF1 is seen in 1 in 3,000 individuals. And the reason why we have such a great population of those kids at Seattle Children's is because they present typically in infancy and childhood. This is contrasted by NF2, which again, different tumor predisposition syndrome. It is a little bit more rare, and it's seen in 1 in 25,000. And also the presenting symptoms typically happen more in adolescence or early adulthood, which is why we may see some of them at Seattle Children's, but typically there will be presenting more in the adult stages. And then schwannomatosis, again, a separate entity, is even more rare, about 1 to 40,000, and that almost always presents in adulthood. And just wanted to highlight that these are all very different conditions, and they have very different tumors that are associated with them. And unfortunately, back in the day, everyone called everything a neurofibroma, and even in the conditions where there aren't neurofibromas. So in NF1, neurofibromatosis type 1, the common CNS tumors that we will talk about are these low-grade gliomas, more specifically optic pathway gliomas. And then they can have peripheral nerve sheath tumors, neurofibromas, plexiforms, and malignant peripheral nerve sheath tumors. And these are all in the neurofibroma realm. Whereas NF2 have very different tumors. In the CNS system, they have meningiomas, ependymomas, and in the peripheral nervous system, they actually have schwannomas. And then in schwannomatosis, they don't actually have any brain or spine tumors. They just have peripheral nerve sheath tumors called schwannomas. So I don't expect you to remember all of that, except to say neurofibromas and schwannomas are different, and NF1, NF2, and schwannomatosis are different. And you can understand, back in the day, before we looked at things under the microscope, a neurofibroma and a schwannoma looked very similar just on gross inspection. But we know that they're actually very different entities, and they also respond to medicines and have a different natural history. And so it's really important for us to understand that on a cellular, molecular level, that these are very different. And so with that, there has been a change into the nomenclature of NF2. Can't change the gene that the name of the gene, but we can at least specify that when we're talking about NF2, it is an NF2 related schwannomatosis, meaning that it is a condition that leads or predisposes to schwannoma development. So hopefully that would clarify, or maybe I just confused you further. One thing that I would also want to highlight is, again, these are 3 separate genetic conditions. NF1 does not turn into NF2, vice versa. They're all on different genes and have different complications. But one thing is really interesting in that now molecular and genetic testing is standard of care. So I will highlight that as our first kind of point. I'm not going to say much further about NF2 related schwannomatosis or schwannomatosis, just because those are less common and probably not what you're going to be seeing most of in your clinics as primary care providers. I will just say, though, that we do have a multidisciplinary NF2 schwannomatosis clinic held once a month. It is with, we have a multidisciplinary group with neurology, neuro-oncology. That role is by myself. And then my partner is Dr. Ruzovic, who is a neurosurgeon. We also have neuropsychology, genetic counseling, and we all like to try to do things in a coordinated fashion with radiology as well as audiology. So that will lead us back to NF1. And I'm not going to go over the diagnostic criteria in detail, but I will say that one change that is very apparent now is that we have this pathogenic NF1 gene variant being one of the possible diagnostic criteria for NF1, and therefore highlighting again that genetic testing is becoming standard of care, which is definitely a change in the field of NF1. With that, I'll move on to the management of NF1, and I have a little cartoon here. We'll go through this cartoon girl's body and show the different manifestations, and also highlight some of your roles as the PCP in this management. So first, we'll talk about the brain. More than half of our kids are going to be having migraines. Headaches are such a common thing that we see in our kids. Unfortunately, I know that that is a problematic situation for some PCPs when we think about some of the other complications that can occur, such as brain tumors. But I will say that it is very common, more than half of our kids will have migraines. Also related to kind of the brain and neurology and the nerves, our kids can have neuropathic pain or an altered sensation of pain as well. We also can see an intracranial vasculopathy, such as moya moya, and 5% of our kids will also have seizures. So, I don't expect you as a PCP to be managing the seizures, but I hope that we can work together and take care of some of the headaches together. So, migraines are not treated any differently than kids without NF1. And the typical headache treatments, water intake, getting regular activity, getting regular sleep, not missing meals, talking about mental health and making sure that those issues are addressed, and then also starting, if indicated, a daily prophylactic such as magnesium and riboflavin. That would go a long way, knowing that so many of our kids do have migraines. Of course, if there is anything that you're worried about, worsening frequency, worsening intensity, or any focal neural findings, please get a brain MRI. But otherwise, I think that there is a great opportunity to partner in the management for this. Still talking about the brain, we'll kind of move into the neuropsychology and psychiatry realm. So, 70% of our kids with NF1 are going to have an IEP, and that can be for cognitive challenges, that can be and or for attention hyperactivity issues and or behavior challenges. So they can definitely be at high risk for these type of issues. We can also see an increased risk of anxiety and depression, as well as autism. And so, what you guys are, I'm sure, all doing, regardless, is asking about school, knowing that they are at high risk of having these cognitive issues and behavioral challenges, also having social challenges with their peer groups, disruptions in the relationship with their parents. And what are the parents concerned about too? Sticking with the brain, we can talk about brain tumors and the role in neuro-oncology. So, as I mentioned before, low-grade gliomas are the type of brain tumor that we most commonly see. Among that type is optic pathway gliomas. And about 25% of our kids with NF1 will have these brain tumors. And I will say that we can partner together and make sure that our kids get dilated ophthalmologic exams because we are not doing screening brain MRIs. And I know that this is sometimes a point of discussion. And so the reason why we don't do screening brain MRIs is because of the 25% of people who do have a low-grade glioma, only 30% of them are actually going to need treatment. So if we are doing screening at brain MRIs, there is going to be a majority of patients who don't need anything done for their tumors other than us sedating them and getting a brain MRI, increasing their anxiety, watching this thing month after month, year after year, and knowing that it's there. So we only do treatment, or we only do brain MRIs if there is an indication to do so. And the most important indication will be optic nerve health, their ophthalmologic exam, visual acuity, visual fields. Right. So we definitely want to make sure that our kids get annual eye checks. And then talking more about tumors, we can go on to thinking about dermal neurofibromas. So dermal neurofibromas are these benign tumors along the nerve. They're cutaneous. You can see them from the outside. Sometimes you can feel them. Sometimes they're just kind of, if you catch the light right, you can see it. So again, they're on the outside. We expect them to have kind of growth throughout their childhood and life, but they're usually asymptomatic. Sometimes it can be a little bit itchy, but Again, they are very common. We expect 99% of our kids by the time that they're 18 years old to have a dermal neurofibroma. So again, a very common manifestation and typically very asymptomatic. And so what we can hopefully do together is to provide some reassurance, because I know parents always get very concerned when we talk about tumors. And yes, this dermal neurofibromas are technically tumors, but that they are generally very asymptomatic. They don't grow very quickly. They don't spread to other areas. We expect to see more of them as the kid gets older. Does not mean that their NF1 is getting worse. Of course, red flags would be if there is a lump or a bump that is very painful, or if it's growing quickly, then that doesn't really fit the MO of dermal neurofibromas, and we should evaluate further. So talking about neurofibromas, dermal neurofibromas are in contrast to plexiform neurofibromas. And plexiform neurofibromas are also these benign tumors along nerves, but they can actually be quite large and involve multiple nerve fascicles. And they can both be visible on the outside, such as this child here, or they can be more internal, such as in the lumbosacral plexus is a common place where we can see them. These typically grow throughout childhood, and you would probably see more of a peak during early childhood and then again through puberty. The problem with these plexiform neurofibromas is that in the past, people try to do resections on them, but because they involve multiple nerve fascicles, it's really hard to do or hard to get a gross total resection. And so after surgery, they will typically grow right back. However, very excitingly, in April of 2020, we now have an FDA-approved medicine called selumetinib, which is in the class of a medication called MEK inhibitors. And this is actually FDA-approved for these plexiform neurofibromas in our kids with NF1. It's an oral medication, so we don't have to put a port in. It's not a chemotherapy, it's a targeted agent. And it has really changed the face of NF1. So this is the same child as this child here, which is really remarkable. He has definitely been the poster boy, literally, for NF1 and selumetinib use. This isn't something that we just do casually, though. We definitely do close safety surveillance. There are some side effects, most commonly rashes that can occur and can actually be quite serious if not properly attended to. And we also have to look at retinal exams, echocardiograms, EKG, and laboratory or blood labs for liver function, kidney function, as well as for the muscle enzymes CK, because those can all definitely be affected with this medication. But we have had great success in the usage of MEK inhibitors, and this is just one example from from one of my patients who had who had this cervical plexiform neurofibroma that was actually compressing her cervical spinal cord. And after being on medication for 2 months, we were able to avoid a very risky spinal surgery that the neurosurgeon was not excited about. And and start to see reduction in the size of the cervical plexiform neurofibroma, with now being able to see CSF flow around that spinal cord. And 6 months on treatment, you can see even further decrease in the size. And unfortunately, the spinal cord just has myelomalacia from being compressed for so long, but she is not vent dependent. She is walking great. She has full strength throughout, and we definitely are very happy with the outcome of the situation using the MEK inhibitor. So kind of key points to think about plexiform neurofibroma. When I said that the MEK inhibitor was FDA approved, it was for symptomatic or inoperable, and thankfully, disfigurement is considered symptomatic. So this is a medical treatment that is available for a wide range of plexiform neurofibromas, including the indication of disfigurement. things to watch out for that may make you think that maybe it's time to use a plexiform neurofibroma for our patient would be if they have a plexiform neurofibroma that's causing pain, weakness, numbness, or any bowel bladder issues. That would definitely be a reason to start. I will say that we do not do whole body MRIs, again, with the understanding that we only do treatment for things that are symptomatic, and that there are going to be plenty of plexiform neurofibromas that are not symptomatic, and doing a whole body MRI and then having to do repeat MRIs and increase anxiety for things that we are not going to be even treating doesn't quite make sense yet. But that is ... being studied and to be determined. Again, red flags, rapid growth, severe pain. Let's see. So then moving on to the other management of NF1, we definitely pay attention to hearing in our kids. They can have 5% of our kids can have sensory neural hearing impairment, or if they have a plexiform or other tumor causing conductive hearing impairment, that's also a possibility. So we definitely recommend our kids to have audiology evaluations, or a school or in clinic hearing screen at least every 2 or 3 years. Let's see. Hypertension is another common complication of NF1. And I guess she lost her kidneys and she got squished there. And it can be essential hypertension, so just plain old hypertension, or it can be secondary to a vasculopathy in their kidneys, so renal artery stenosis. And so the way that we would like to partner together is we always try to do blood pressure checks at every visit. And for us, we always do manual blood pressure checks instead of automated, just because we find those to be much more accurate. Another really common thing I say, all my kids with NF1 have constipation and belly pain. And the top 3 reasons for having belly pain in a kid with NF1 is going to be constipation, constipation, constipation. Of course, there are other things we can think about, but we definitely like to partner with our PCPs and have good, frank poop talks and very aggressive Miralax and high fiber food discussions. Another complication with our NF1 kids can be hormone dysregulation. And so they can have short stature or early or late puberty. And so for our PCPs, we thankfully can see and sneak into your growth charts typically. But if you're noticing for the child with NF1 that you're seeing that their linear velocity is definitely changing, or it seems like they are going through puberty sooner or later, please definitely keep in mind that there can be hormone dysregulation. Not always associated with a pituitary or hypothalamic tumor. It can just be by itself as well. And I will say the average height percentile for our kids with NF1 is 10th percentile. So instead of 50th percentile being your average, 10th percentile for the height is very is normal for them. So it is not just your imagination. Our kids with NF1 are shorter typically. And then genetics. So like I mentioned, genetic testing is now becoming more standard of care. And the reason why is we're getting smarter and understanding that even if someone, say, meets clinical criteria for NF1 based on pigmentary findings, there are still other genetic syndromes that could be, such as Leigh syndrome or constitutional mismatch repair deficiency. And these all have very different prognoses. And so we definitely talk about molecular testing and try to manage that for our kids. It can help with early diagnosis, identification of mosaicism, family planning in the future, and there's still much to be learned about any genotype phenotype kind of connection with the NF1 variant and their phenotype. I will say there's speech and language delay that is very commonly seen, and we want to make sure that we get their hearing screened to see if there's any kind of complications secondary to the hearing that could be influencing their speech and language. Scoliosis is very common as well, so we would ask our PCPs to do a forward bend spine check to check for scoliosis. It's the same thing that we did in middle school. You bend over and you look at their spine. And then our social worker is really crucial in the management of NF1 because there's so many psychosocial burdens for our kids and their families with NF1. They can have multiple complications. Half of these kids are going to have parents with NF1 with their own complications. So that is definitely something that we take into considering when we're trying to take care of our kids. So we have a big team, myself and Lauren Levesque. She's my partner in the management of typical NF1, as well as for the brain tumors and the other plexiform neurofibromas, and we lead the multidisciplinary teams. So we see patients essentially every day who have NF and usually NF1. But we also have a combined clinic with myself or Lauren, also with genetics, and this is held twice a month. And we have our genetics nurse practitioner as well as our genetic counselors. We have weekly neuropsychology NF multidisciplinary clinic with our neuropsychologists, Dr. Bowen and Dr. Patrick. We have monthly rehab multidisciplinary clinic with our physical therapist, Jacob Ross, and our occupational therapist, Sadie Hobrick. And so we definitely try to coordinate the care and try to make it as seamless as possible, understanding that there are many complications and things that make taking care of a child with NF1 pretty tricky. So we have a team with our nurse program coordinator, our social worker, our scheduler, as well as our admin support too. And we all work together to advocate and educate. I did want to just highlight real quick in the last bit here that we definitely are strong advocates for education. And so this is a QR code for a YouTube video we made for educating our families about NF1, understanding that sometimes YouTube might be the way that people learn best. We have educational handouts as well. We give comic books to our kids to help them understand NF1. We have our summer camp for our kids. We all do an annual NF walk in Seattle. And we also hold an annual Seattle Children's NF Symposium for families and providers. And last year's topic was learning as well as NF2 related schwannomatosis, and this year's is to be determined. To refer to our program, the NF program is in Seattle Children's Neurology. If you can, it doesn't have to be in your referral, but in your note, if you can include what you're worried about, what you see on exam or even photos, why are you referring them to the NF program now, and any other kind of complications, knowing that we can triage them to be seen in any multidisciplinary clinic. And then we'll always ask for you to see or to have an ophthalmology local referral too. If you have questions, please ask us. And so your role, hopefully as a PCP, blood pressure checks, forward bed checks, make sure our kids see ophthalmology annually, talk about audiology, hearing every 2 to 3 years, and then make sure that we can see them in our NF programs to see an NF specialist annually. Like our testing is becoming standard of care, we definitely think of ourselves as the NF medical home in neurology for our kids, and that we would definitely love to work with you and send us an email if you have any questions, if you're finding that your patients are getting stuck in triage. And that is all I have. Thank you very much.
Thank you. That was great presentation. Oh, it's echoing. My voice is echoing. I'm sorry about that. So I don't see any questions in the chat box, but if you would like to ask your question verbally, you can go ahead and raise your hand and we will unmute you. So we'll wait a minute here to see if anybody has a question that they would like to ask verbally. Oh, here's a question. What is the pathophysiology of the cafe au latte muscules and NF1?
Yeah, so the pathophysiology, so I can definitely pull up a slide, but essentially those skin cells that within the cafe au lait macule, they have a homozygous deletion of the NF1 gene. So it can be part of the gene or the entire gene, but either way, they have a homozygous variant in that area. Now, the NF1 gene is really important in creating protein neurofibromin, and then that neurofibromin is is necessary in the regulation of certain cells in their cell cycle pathway. And so, for those cafe au lait macules, they have the rampant increase in the pigmentation cells due to not having a functional neurofibromin to block that cell cycle pathway. Hopefully that made sense.
And the other question was, should referrals go straight to your program or derm or ophthalmology?
Definitely, so our Seattle Children's Ophthalmology, the wait list is like, I don't know, a year, 2 years, 5 years, not sure. But for our kids with NF1, so what we're doing is we are recommending you get a local ophthalmology evaluation for anyone who you are concerned about having NF1. If you are, again, and this is why in your note or your referral, if you say what you are worried about, we can triage, because if it's a patient that just has cafe au lait macules, we have a rule out NF clinic. If you have someone who clearly meets clinical diagnostic criteria because they have freckling, family history, dermal neurofibromas, whatever have you, if they already meet clinical diagnostic criteria, they should just be seen by us in the NF program, and we can go from there. But either way, just send it to us. We'll figure it out. But the more information that you can provide in the referral would be helpful.
I put in the chat, the same goes for our program. We're happy to see anybody with rule out TSC in neurology, and then we will refer on as needed.
That's great. So I don't see any more questions. Let's see. And yeah, so we will be sending out the recording and the slides. It should take probably like a week at least for the recording to be done. And then I really appreciate that you guys put your contact information on the slides. That was very nice of you guys. So thank you so much. This was an excellent presentation, and we really appreciate you guys taking the time to speak too.